Usually, when we picture the human body's defense system, we kind of picture it like this highly disciplined fortress. You get a scraped knee, which is just a tiny breach in the outer wall,
Right.
and the cellular guards, they rush in, they neutralize the invader, patch the wall, and everything just goes back to normal. The narrative is super clean, it's proportional, and honestly, it's pretty comforting.
Oh, absolutely.
Yeah.
I mean, we rely on that predictability. Threat neutralized, situation resolved, move on with your day.
But the stack of sources we are diving into today for this deep dive outlines a medical mystery that completely shatters that comforting narrative. It's this phenomenon hiding in plain sight. We're looking at what happens when those cellular guards don't just panic, but they actually set the entire fortress on fire.
Yeah, they basically tear down the remaining walls themselves.
Exactly. We're exploring the sepsis cascade, so how a routine localized infection can suddenly trigger a catastrophic system-wide collapse of the human body.
And I think we need to establish right away that the global stakes of this biological betrayal are just staggering. Like, we're not talking about a rare esoteric medical anomaly here.
No, not at all. Look at this statistic from the sources. There's a 2020 Lancet analysis by Christina Rudd and her colleagues. In 2017 alone, there were 48.9 million sepsis cases worldwide.
Yeah, and 11 million of those resulted in death.
11 million. I mean, that is nearly 1 in 5 deaths globally. That dwarfs so many of the well-known chronic diseases that usually dominate our health conversations.
It really does. Which means there is a massive paradigm shift we need to address immediately, because the fundamental public understanding of what sepsis actually is remains, well, largely incorrect.
Okay, let's unpack this. What do people usually get wrong?
Well, people tend to think of sepsis as just a really severe infection, or like a particularly aggressive superbug. But sepsis is not the germ.
Okay, it's not the germ.
No. The official clinical definition, which is currently known as sepsis 3, defines it as life-threatening organ dysfunction caused by a dysregulated host response to infection.
So it's about the host response.
Exactly. Notice the phrasing there. It doesn't specify that the infection is actually spread to your blood. It doesn't even require a positive blood culture. Sepsis is strictly about what your own immune system does in response to a germ when that response stops protecting you and starts basically destroying your own organs.
Right. So for you listening to this deep dive, our mission today is to uncover exactly how this microscopic betrayal happens. We're going to explore why modern medicine has spent literally decades arguing over how to even define and cure it.
And why understanding this cascade is absolutely crucial for anyone navigating the healthcare system today.
Yeah, because if the problem isn't just the germ, how do doctors even know what they are treating?
That is the million-dollar question. To understand why medicine has argued with itself for so long, we really have to look at the incredibly shifting history of the definition. You can't effectively treat a condition if the medical community can't even agree on the parameters of the disease.
Yeah, and I was actually amazed to read in the sources that the word itself is ancient. Like, Hippocrates was using the Greek word sepsis way back in the 4th century BCE.
Right, but he obviously wasn't talking about an immune system response back then.
No, he was using it to describe the literal visual and olfactory process of flesh rotting. Like you'd see in a severe wound or like a compost heap. Just awful.
Well, for 2,000 years, the concept of microscopic germs just didn't exist in medicine. So sepsis was categorized purely by smell and sight. It actually wasn't until 1914 that a German physician named Hugo Schottmuller proposed a more modern clinical framework.
Okay, and what did he say?
He tied the concept explicitly to bacteria invading the bloodstream from an infection site. This is actually where the term blood poisoning entered the public lexicon. And honestly, that shaped medical assumptions for most of the 20th century.
Which, as we now know, is fundamentally incomplete. But I guess medicine loves a good standardized framework. Which brings us to August 1991, right?
Yes, the 1991 Consensus Conference. Intensive care doctors were realizing their clinical drug trials were failing left and right.
And that was largely because every hospital in the country was defining sepsis differently, right?
Exactly. So they had this massive conference, heavily associated with a pulmonologist named Roger Bone, and they created a new checklist called SIRS. That's S-I-R-S. The Systemic Inflammatory Response Syndrome.
Right, SIRS. Think of SIRS like a checklist of biological fire alarms. The criteria basically stated that if you had an infection and you triggered 2 of these 4 alarms, so that's fever or hypothermia, a fast heart rate, fast breathing, or an abnormal white blood cell count, you were officially categorized as septic.
That was the standard. It was an attempt to standardize research by creating a tiered vocabulary
Yeah.
based entirely on vital signs and lab abnormalities.
But wait, I have to push back on this a little bit. If I run up a steep flight of stairs, my heart rate and my breathing are going to spike significantly.
Well, absolutely.
And if I happen to have a mild seasonal flu on top of that, I've got a fever. So wouldn't I trigger this massive sepsis fire alarm checklist just by being out of breath while sick?
You absolutely would. This raises an important question, and you just hit on the exact problem that became glaringly obvious over the next 2 decades. Half the patients in any given hospital met the service criteria at any given time.
Wow, half. That's wild.
Yeah. Someone recovering normally from routine surgery or someone with a mild virus, they would trigger the alarms. So SIRS was incredibly sensitive, meaning it cast a very wide net, but it completely lacked specificity.
So it was almost useless for distinguishing the person who just had a standard fever from the person who was actively entering a dysregulated fatal immune collapse.
Right. It's like having a smoke detector that is so sensitive it goes off every single time you make toast.
I hate those. Eventually, you just take the batteries out, you stop trusting the alarm altogether.
And that frustration led directly to the modern fix in 2016. A task force led by intensivist Mervyn Singer and pulmonologist Clifford Deutschman published the Sepsis 3 definition in JAMA.
And what did they do with SIRS?
They looked at the SIRS checklist and basically threw it out the window entirely. They shifted the core focus away from inflammation and entirely toward organ dysfunction.
Okay, and they measure this using something called the SOFA score, right? The sequential organ failure assessment.
Yes, exactly. The SOFA score objectively tracks failure across the lungs, kidneys, liver, the coagulation system, the cardiovascular system, and the brain. If your score jumps by 2 or more points due to infection, boom, you're diagnosed with sepsis.
And they also redefine the most severe tier, septic shock. So that is now defined as sepsis plus persistent low blood pressure that requires vasopressor drugs to keep it artificially elevated.
Right, combined with high blood lactate levels despite receiving intravenous fluids. And that specific combination, it carries a hospital mortality rate above 40%.
It's terrifying. But even with this new Sepsis 3 definition, the sources show this isn't a completely settled debate, is it? Emergency room doctors have actually pushed back pretty heavily on the SOFA score.
They have, yeah. Mostly because SOFA requires waiting around for laboratory blood draws to check liver and kidney function. When you're in emergency triage and minutes matter, you don't always have time to wait for a lab centrifuge to spin.
Right. Time is of the essence. So what's the alternative?
Well, that practical reality forced the introduction of a simplified bedside version called QSOFA, Quick SOFA. It doesn't require labs. It just looks at 3 immediate clinical signs: altered mental status, a fast respiratory rate, and low blood pressure.
But the debate rages on today, right? Because QSOFA was almost immediately criticized by other factions of medicine for missing early cases.
Yes. The critical takeaway here for the listener is that there's currently no perfect definition. Clinicians are operating on the current best compromise between speed and accuracy.
Okay, so that's the definition problem. But I'm trying to picture how this microscopic betrayal actually begins on a cellular level. You know, if I get that scraped knee we talked about, how does my immune system even recognize the bacteria to trigger this massive dysregulated response in the first place?
It's fascinating. The pathophysiology is incredibly complex, but the initial trigger is all about molecular recognition. You have immune cells, like macrophages and dendritic cells, constantly patrolling your tissues.
Like little security guards.
Exactly. And their surfaces are covered in toll-like receptors, or TLRs, which function essentially like molecular barcode scanners. They aren't looking for a specific germ, they're scanning for broad molecular signatures of invaders. And the classic example the sources use for this is LPS, right? Lipopolysaccharide, which is a structural piece of the outer wall of certain bacteria. Yes, LPS is a huge one for gram-negative bacteria. When a patrolling cell's TLR scans that LPS barcode, it confirms an invasion. The cell immediately releases chemical alarm signals called cytokines.
And normally that's a good thing, right?
Right. In a functional, normal response, these cytokines recruit more immune cells to the area, they raise your local body temperature to make the environment hostile to the germ, and they sort of wall off the infection site.
But here's where it gets really interesting, or terrifying, honestly. In sepsis, that alarm system gets jammed in the on position.
Yeah, it becomes what we call a cytokine storm. The response gets too large, spreads system-wide, or lasts far too long. And the sources detail a sequence of 4 devastating downstream effects when this cascade gets out of control.
Okay, let's break those down. Effect number 1.
The first major failure happens in your blood vessels. So your vessels aren't just bare biological pipes. They're lined with a protective, slippery layer called the glycocalyx.
Sort of like a microscopic Teflon coating that keeps the blood flowing smoothly.
Perfect analogy. But the cytokine storm is highly toxic to that Teflon coating. It actively degrades and shreds the glycocalyx. Suddenly, your capillaries become extremely permeable.
So they get leaky.
Extremely leaky. Fluid starts pouring out of your blood vessels and leaking into the surrounding tissues. This is why patients in severe sepsis develop profound full-body edema or swelling. But the more critical issue is mechanical. Because all that fluid volume is leaving the pipes, your blood pressure completely crashes.
Right. And that leads to a state called distributive shock, which is fascinating to me because it's fundamentally different from what we normally think of as shock. Like if I get cut and lose a massive amount of blood on the floor, I have hypovolemic shock because my body physically lacks fluid.
Correct. You've lost volume.
But in distributive shock, the fluid is still inside my body. It's just in all the wrong places. It's flooding the tissues instead of filling the pipes. So the heart starts pumping furiously to compensate, but there's no pressure to deliver oxygen to the major organs.
Exactly. And that sluggish blood flow from those leaking low-pressure pipes triggers the second devastating effect in the cascade. Coagulopathy, specifically disseminated intravascular coagulation, or DIC.
Oh boy. DIC.
Yeah. The same inflammatory cytokines that shredded the vessels also act as a panic signal to your blood's clotting system. The body senses widespread vascular damage and attempts to patch it by forming thousands of tiny microscopic clots everywhere in your small vessels.
This part sounds like an absolute physiological nightmare. The body forms these microclots so rapidly and in such high volume that it completely consumes all of your available platelets and clotting factors.
Right. It uses up all the supplies.
So you are simultaneously suffering from thousands of microclots choking off oxygen to your kidneys and liver, and you are bleeding spontaneously from your gums, your mucous membranes, and IV sites because you literally have no clotting factors left to stop a normal bleed.
It is a dual horror of clotting and hemorrhaging happening at the exact same time. The medical literature highlights a really dramatic historical example of this mechanism to illustrate just how brutal it is. Waterhouse-Friderichsen syndrome.
Oh, I read about that from the early 1900s, right?
Yes. It was first described in infants by Rupert Waterhouse in 1911 and Carl Friderichsen in 1918. They documented cases of an overwhelming meningococcal bacterial infection that caused massive spontaneous hemorrhage directly into the adrenal glands.
Wow.
Yeah, they were meticulously documenting the lethal end stage of DIC decades before anyone understood the underlying cytokine storm that was actually causing it.
Okay, let me play devil's advocate here for a second, moving to effect number 3. If the primary physical problem is that the capillaries are leaking fluid and losing pressure, shouldn't we just be able to pump the patient full of heavy IV fluids, give them some vasopressor drugs to physically squeeze the pipes, blast them with pure oxygen, and just watch them recover?
It is the most logical assumption. And honestly, it's exactly what critical care tries to do first. But it often fails because of a deeply frustrating phenomenon coined by researcher Mervyn Singer called cytopathic hypoxia.
Cytopathic hypoxia, what does that mean?
It means that even when critical care doctors perfectly restore blood pressure and ensure oxygen is being delivered right to the front door of the cells simply refuse to use it. The mitochondria, the cellular engines that process oxygen into energy, they essentially shut down due to the overwhelming inflammatory stress.
So you could be perfectly oxygenating a patient, essentially putting a massive feast right in front of their cells, but their cellular digestive system is completely turned off and they starve to death anyway.
Exactly. The organs continue to fail despite perfect vital signs on a monitor. And this brings us to the fourth effect, which is the most surprising twist. Most lay explanations of sepsis just skip this part entirely.
Yeah, this part blew my mind.
It's called CARS, compensatory anti-inflammatory response syndrome.
So the pendulum swings the other way.
Violently. Patients who survive the initial hyperinflammatory cytokine storm often swing into a state of severe, profound immune suppression. We call it immunoparalysis.
So their immune system just gives up.
Essentially, yes. The immune cells, particularly T cells, literally undergo apoptosis. They commit programmed cellular suicide. The immune system just completely exhausts itself.
Meaning a huge number of sepsis deaths in the ICU, especially the ones that happen a week or two after admission, aren't actually from the original scraped knee or the original bacteria at all.
Not at all. They're from secondary hospital-acquired bacterial or fungal infections that a healthy immune system would have just swatted away effortlessly. Sepsis can kill you twice. First by overreacting and later by giving up entirely.
Man, so understanding this terrifying cascade leads to a really urgent question. How do we stop it? Because time truly is tissue here.
It is. The sources cite a landmark 2006 study by Anand Kumar. They looked at nearly 3,000 patients suffering from septic shock, and they found that for every single hour of delay in starting effective intravenous antibiotics after a patient's blood pressure drops, there's a 7.6% increase in mortality.
Every single hour. That is an incredibly steep penalty for waiting. And that specific data point became the founding rationale for the Surviving Sepsis Campaign's famous Hour 1 bundle, right?
Right. The protocol dictates that within 60 minutes of recognizing sepsis, doctors must draw blood cultures, measure lactate levels, administer broad-spectrum antibiotics, and start rapid fluid resuscitation.
But wait, if the core of this entire early cascade is a massive runaway fire of inflammation, why can't we just give these patients heavy-duty anti-inflammatory drugs? Like, why not just spray a chemical fire extinguisher on the whole system to stop the leaky pipes and the clots?
What's fascinating here is that your intuition perfectly matches decades of intense medical research, and yet it has proven deadly wrong in practice. The sources outline a literal graveyard of anti-inflammatory drugs.
Great.
Yeah. Pharmaceutical companies developed anti-TNF antibodies and targeted receptor antagonists that worked beautifully to stop sepsis in mice.
But in humans?
They failed spectacularly in almost every human clinical trial. Broadly suppressing the inflammation often backfired because it completely ignored that final twisted phase of the cascade we just talked about, CARS. If you give a patient a massive anti-inflammatory drug on day 1 to stop the storm, you often guarantee they will die of immunoparalysis on day 10.
Oh, because you're suppressing a system that is about to suppress itself anyway.
Exactly. You're pushing them off the cliff. The history of trying to treat this is just full of massive billion-dollar examples of hubris.
Yeah, look at Tigris. In 2001, this drug gets fast-tracked FDA approval based on the Prowess trial. It was designed to intervene in the coagulation cascade to stop the massive microclotting of DIC we talked about.
Right.
And it was hailed globally as a massive breakthrough, like the very first drug ever approved specifically for severe sepsis.
And then, a decade later, the follow-up trial, Prowess Shock, showed the drug had absolutely zero survival benefit for patients.
Zero.
None. The manufacturer, Eli Lilly, had to withdraw it from the global market entirely. It remains one of modern medicine's clearest cautionary tales about rushing to adopt a treatment based on a single positive clinical trial without fully understanding the broader cascade.
But it wasn't just specific drugs that failed in this graveyard. It was entire complex treatment protocols. The sources detail Emmanuel Rivers' early goal-directed therapy, or EGDT, published in 2001. His single-center trial showed this incredibly aggressive, heavily monitored resuscitation protocol cut mortality from around 46% down to 30%.
Which is huge.
Huge. It changed emergency medicine worldwide overnight. But then, a decade later, 3 massive multi-center trials, Process, Arise, and Promise, they all showed his specific invasive protocol was no better than just providing good standard critical care.
Though the medical consensus isn't necessarily that Rivers was wrong in his approach, it's more that his central insight, which was to recognize and treat septic shock incredibly fast and aggressively, had been fully absorbed into the standard baseline of care by the 2010s.
Ah, I see. A rising tide lifts all boats.
Exactly. The baseline care got so much better that his specific complex catheter protocol didn't offer an incremental edge anymore over simply paying close attention to the patient.
That makes sense. Yet we keep falling into the same trap of looking for a silver bullet. Even recently, the sources mentioned the Merrick protocol from 2016. A doctor claimed that intravenous vitamin C, thiamine, and hydrocortisone was essentially curing sepsis.
Yes, that became a huge media fad. Hospitals everywhere started using it until rigorous multi-center trials like the vitamins trial proved conclusively that it didn't actually have a meaningful survival benefit.
So we synthesis all these failures, and it really comes down to the one-size-fits-all problem, doesn't it?
It does. Human sepsis is not one single uniform disease. It is a heterogeneous, final common pathway. We are taking hundreds of different infections in patients with entirely different genetics, ages, and pre-existing conditions and trying to treat them all with a single, standardized biological intervention.
Which brings us to the real-world impact for you, the listener, because understanding this pathophysiology isn't just about analyzing clinical trials, it's about recognizing the very real danger in everyday life.
Right. We need to debunk several dangerous myths that actively prevent people from spotting sepsis before it's too late.
Okay, let's do it. The first major misconception is that sepsis strictly means you have blood poisoning, meaning bacteria is actively swimming in your veins.
Which is completely false. Blood cultures are totally negative 30 to 50% of the time in clinically diagnosed sepsis cases. Because the cascade is triggered by the host's chemical alarm response, a purely localized infection, like a urinary tract infection, pneumonia, or a skin abscess, can trigger the system-wide vascular collapse without a single bacteria ever crossing into your bloodstream.
There's also the myth that sepsis is just a really, really bad infection, assuming the bug itself is just super virulent.
Again, false. Two people can be exposed to the exact same strain of bacteria with the exact same initial bacterial load. One person develops a mild, annoying cough. The other rapidly enters distributive shock and multi-organ failure. The determining variable is the host's unique, individualized immune response.
Which is shaped by their genetics, their age, their prior lifetime exposure to antibiotics, everything.
Exactly. It's about the host, not just the germ.
And we also tend to think of sepsis as strictly a hospital problem, right? Like something that only threatens the elderly or people with severely compromised immune systems.
Yeah, it's a huge myth. Most sepsis cases actually begin out in the community long before the patient ever sees a hospital. And it absolutely does, strike previously healthy individuals of any age.
Yeah, the sources cite the tragic case of 12-year-old Rory Staunton in 2012. He was a completely healthy kid who got a minor scrape playing basketball. The early, subtle signs of the sepsis cascade were completely missed in the emergency room, and he died.
It's heartbreaking. But that tragedy actually led to the implementation of Rory's regulations in New York State, which legally mandates rapid sepsis recognition protocols in all hospitals to catch those early vital sign shifts.
And if we connect this to the bigger picture, understanding the mechanics of this cascade has never been more relevant than it is right now. I mean, we just lived through a global event, severe COVID-19, where the primary mechanism of severe illness and death was largely understood through this exact sepsis and cytokine storm framework.
Yes, the viral infection triggered the exact same dysregulated hyperinflammatory vascular collapse.
It's not just viruses either. The sources point out that revolutionary cancer treatments like CAR-T therapies are running into this exact issue. Oncologists are suddenly having to become experts in sepsis physiology.
Because these brilliant immunotherapies, which engineer T cells to attack cancer, can accidentally trigger the exact same catastrophic cytokine release toxicity.
So what does this all mean? When we step back and look at the whole picture, sepsis is just the ultimate double-edged sword.
It really is. The very immune systems that have evolved over millions of years to save your life can suddenly become dysregulated, malfunction, and literally destroy you from the inside out.
Yeah. The clinical definition is constantly shifting to catch it faster. The mechanism is a terrifying two-part trap of a fiery cytokine storm followed by cold immunoparalysis, and there is absolutely no magic bullet drug to fix it. There is only time, rapid recognition, and highly tailored critical care.
But I'll leave you with a final thought to mull over. We've spent decades searching the treatment graveyard for a single drug to cure this syndrome. But what if the future isn't a new medication at all?
What do you mean?
What if the real breakthrough will be a real-time immune dashboard? Imagine a technology that can instantly read a patient's biomarkers at the bedside and tell a doctor exactly where they are in the cascade.
Oh, wow.
Right. It could say, this patient is currently in the hyperinflammatory cytokine storm. Or, no, this patient has already swung into the immunosuppressed CARS phase.
That would change everything.
It would. If your body's fortress is on fire, the doctors need to know whether to send in the fire trucks with water or the builders with supplies. Right now, they're often just guessing in the dark. A dashboard would allow them to finally treat the specific phase of the cascade that the unique patient is trapped in, rather than treating the general syndrome blindly.
That is incredible to think about. Well, thank you for joining this deep dive. Keep asking questions, keep challenging the simple narratives, and stay curious.